We are live.
Good evening, everyone. Welcome to the iFocus online lecture number 475, the refractive surgery module number 26. Today, the topic for discussion is post-refractive surgery enhancement, which will be taken up by Dr. Kanika Bhardwaj, ma'am. Welcome, ma'am. The moderator for today's class is Dr. Pratiksha Sharma, ma'am. Ma'am has done her MBBS from Lady Hardinge Medical College, New Delhi. She's done her MS from the Maulana Azad Medical College, Delhi. Ma'am has completed her senior residency at Guru Nanak Eye Center, New Delhi. Currently, she is the associate consultant at Centre for Sight, Haryana. Previously, ma'am has worked as specialist ophthalmologist at ESI Hospital, Haryana. She is the recipient of Champions Award at YOSI. She has received distinction in medical training and authored over 30 journal articles and given over 40 presentations and lectures at various ophthalmic meetings nationally and internationally. Welcome, ma'am.
Thank you, Sylvie.
The chairperson for today's class is Dr. Rupal Shah, ma'am. She's the practice surgeon practicing since 1994. She was the first person in the world to do one incision smile surgery and hence has been fondly described as the mother of smile. First, she is also the first in the world to use circle software in a patient for retreatment in smile. She has trained more than 2,000 ophthalmologists from across the world. Successfully, she has conducted 77 intensive LASIK training course, which was attended by around 20 ophthalmologists. She has many national and international publications and presentations, and also she's the recipient of numerous awards and gold medalists. Welcome you, ma'am. The speaker for today's class is Dr. Kanika Bhardwaj, ma'am. Ma'am has done her MBBS from Government Medical College, Salem, Tamil Nadu. She has done her DNB Ophthalmology from Eye Care Eye Hospital and Institute, Noida. Ma'am has done her fellowship in cataract and refractive surgery from Center for Sight, Eye Institute, New Delhi. Currently, she is an associate consultant in Center for Sight, uh, New Delhi, Dwarka. She is the cataract and refractive surgeon. She is involved in training DNB and PG students and mentoring the fellows. She is the recipient of multiple awards for Best Video, Best Paper, Best Poster at AIOS, DOS, WS, and various other conferences. She has received Young Researchers Award for her thesis as well. Ma'am has multiple publications on cornea, cataract, and refractive procedures in various national and international journals. Welcome you, ma'am, and over to you, ma'am.
Thank you so much, Sylvie. So I hope my slides are visible now.
Yeah.
Yes, ma'am.
So without further ado, let's jump in today's topic. Today's topic is post-refractive surgery enhancement. So what does post-refractive surgery enhancement mean? It is actually a procedure or an additional surgical procedure which is to be performed after an initial refractive surgery was done, and mainly it is done to fine-tune or improve the visual outcomes. Usually, 3 to 5% of people require an enhancement procedure. However, various reports they give different values and they can be even as high as 18% in some cases. The correct incidence is still not known. However, it's not very usual as well. With the current technologies which have advanced drastically, the incidence for post-refractive surgery enhancements has also come down. So it is defined as an early enhancement when it is done within the first year, and usually it is because of any residual refractive errors, because of any over or under correction. The late one is either due to regression or progression of myopia or axial lengthening, or even people who want to get rid of their presbyopic glasses, and it can also be associated with ectasias. So, what are the types of enhancement procedures? Basically, we can do a LASIK enhancement, that is, for a person who had already gotten a LASIK done previously, we can just lift the flap and perform the additional excimer correction. We can also do a PRK enhancement or a surface ablation. This can be done in all procedures, even when the previous history is not known, and especially in cases where the cornea is too thin for another LASIK or a lenticule procedure. Then we have smile enhancement. So as the name suggests, smile enhancement is done for people who already had a lenticule surgery done, where we can further convert the smile cap into a flap, or we can even go for a surface enhancement in such cases. Lastly, for people who are not suitable for cornea-based enhancement procedures, an intraocular lens enhancement, whether it could be a phakic IOL or a refractive lens exchange, is also an option. So let's talk about the major scenarios that we encounter when it comes to talking about enhancement after a primary refractive surgery. So it could usually be insufficient primary procedure. That is, during the surgery, something happened which led to some residual error or some complication or some issue on the part of the surgeon or intraoperatively, which led to the primary presentation. And as the name suggests, this usually presents very early. Mostly if it is an undercorrection or an overcorrection, the patient will be not satisfied within the first week of the surgery when the healing process is still going on. It could also be sometimes an unregulated healing response to an absolutely uncomplicated surgery. And sometimes there could be intoward intra-op complications, which neither the surgeon nor the patient was aware about. So these procedures usually do not come under the category of enhancement, because traditionally enhancement is referred to those procedures which are done over a period of time. So secondary changes can also happen over a period of time after an uncomplicated previous surgery. It could also lead to regression or ectasia, or it could be due to chronic changes in the axial length or index myopia, or sometimes dry eyes or other inflammatory changes that happen over a period of time. The most important factor is that we should also discern or differentiate the patient dissatisfaction from the actual presentation of a residual refractive error. Sometimes some patients come to our clinic and they can simply complain of blurring of vision or doubling of vision as the day progresses. So we have to also rule out the possibility of dry eye disease and not take every complaint very seriously and jump to the conclusion of a retreatment. Now, what is the concept of over and under correction? It's a basic concept. I'm sure everybody is already aware of it, but it takes a little bit time to just mention it here. So let's say a person who has myopia and whose cornea and lens together are not able to focus the light rays entering the eye from infinity on the retina, but a little before it. So the whole purpose of our treatment or a refractive surgery is to convert such a patient to emetropic state. That is, when the light can be focused on the retina by altering the power of the cornea, as we do in the laser vision corrections. However, due to any surgical or intraoperative issues, if let's say the laser fired is more or the corneal flattening achieved is excessive, so now this ray, instead of focusing on the retina, would be focused behind, and hence by overcorrecting we have now turned the myopic patient to a hyperopic. Similarly, due to some reasons, due to some debris occluding during the excimer laser firing or something which led to undercorrection or less firing of the cornea and less flattening of the cornea, would eventually lead to these rays focusing behind the initial point but still not up to the retina. So this could be called as residual myopia. So it is very important whenever a patient turns up, we have to find out the previous history to know whether it was a primary over or under correction, or whether it is a gradual progressive change that has occurred over time. So the concept of regression and also of the post-LASIK ectasia has been taken beautifully by Dr. Himanshu in the previous class to this. Please go back and understand about the concept of ectasia and regression, because going too much into detail would be out of this class scope. So coming to the basic difference, when we have to do an enhancement, the first and foremost thing that we need to understand is whether it is a case of regression or ectasia, because treating one and ignoring other may lead to drastic results and even sometimes very legal issues as well. So if it is a regression, it is very suitable for enhancement, but if it is ectasia, it is not suitable for immediate enhancement. We have to think of other things like stabilizing the cornea first. So the priority is not refractive correction then, the priority is stabilizing the pre-existing weakness in the cornea. So this is a basic difference in the treatment approach when we talk about regression or ectasia. So regression could be caused because of mild biomechanical changes or even epithelial hyperplasia. So epithelial hyperplasia plays a major role here, whereas ectasia is because of progressive steepening and corneal thinning. Regression usually stabilizes over a period of time. It is not progressive continuously, whereas ectasia keeps worsening and progressing. Now, primary treatment for any regression could be an enhancement procedure or any other procedure depending on the previous surgery that was there. And for ectasia, the primary treatment is for stabilization of the cornea, therefore corneal cross-linking. For non-surgical options, definitely we can give temporary measures like glasses and contact lenses. However, the normal contact lenses do not work as well in ectasia and they may need specialty contact lenses. Apart from that, surgical alternatives also vary because in regression, we can do a repeat refractive surgery procedure, whereas in ectasia, only after once the cornea is stabilized, we can then think of some procedure which can improve the corneal biomechanical strength and reduce the irregular astigmatism that happens. So sometimes procedures like intacs and in worse cases, even a penetrating keratoplasty may be required. So now that we have established the fact that we have to first rule out ectasia and differentiate it from regression, we now come to the clinical assessment of a patient who has turned up into a clinic for a retouch-up or a enhancement process. So before performing a post-refractive surgery enhancement, a thorough evaluation is necessary. Firstly, to determine if the patient is a good candidate or whether he or she will benefit from the process if touched. So first stop, think, and only then act. First determine all the factors and then only proceed to retouch the cornea or the procedure to be planned. Now coming to first point in our clinical assessment, most importantly, you have to know about the patient's history. Many a times patient turn up into the clinic and they have no previous records and no history, but even a 5 to 10 minutes chair time with the patient can give you an indication of what happened in the first procedure and why the patient was unhappy and why he has turned up to you. So as for the symptoms such as blurred vision, glare, halos, night vision problems, what is it that is causing the person to be dissatisfied with his present outcome and why he has turned up here? Sometimes people miscalculate or even put blame on the primary surgeon for every small nitty-gritty problem that they have. For example, people who are too much on screen devices like their computers and phones, they do tend to have more dryness as compared to others. And by the end of the day, they start complaining of a blurred vision. So you have to differentiate whether it is actually a blurred vision due to a refractive error or is it due to asthenopic symptoms. Sometimes people complain of double vision, but actually what they're trying to say is that they see a little bit of a fuzzy light around some light source. So you have to ask them about their symptoms specifically, whether it is a glare or is it a halo or is it a starburst. Next, coming to the satisfaction, we have to assess whether it is the patient's expectations which are out of proportion or is there a genuine problem that is causing him dissatisfaction, him or her. So that has to be seen. If you land up with a patient who has very unrealistic expectations, definitely such a candidate is not a good candidate for surgery again. For example, I recently met a person who was not unhappy with his vision. He had undergone a LASIK procedure and there was very mild haze at the LASIK flap borders. However, the central vision was clear. The only complaint he had was he had pain in his right eye. And that pain was not getting better with lubricants. He constantly complained of pain and somewhere he showed they gave him a suggestion of a PTK procedure to get rid of the haze. Now, when the patient turned up to our clinic, we asked him specifically what his complaint was. He said, I am not unhappy with the vision. I just want something to get relief from this pain. And if a PTK can give me that, I'll be happy. So this is where you have to understand that before offering any procedure, you need to know what actually is the problem of the patient. Such patients They will never be happy once you retouch them and their primary complaint is not solved. So for this particular example, we did not touch his eye again because his vision was good. He had a 6 parts vision. He had no complaints except for the pain. For the pain, we referred him to a neurophysician because we were now suspecting trigeminal neuralgia after giving him complete dry eye treatment for extended periods. Then we also have to assess the stability of the prescription. So any enhancement procedure should not be done immediately. We have to ensure that there are no significant changes and there is at least stability for the past 3 to 6 months, depending upon the refractive error that is encountered. Another point in patient history is to take history of other symptoms apart from the visual disturbance, such as redness or burning or sensitivity to light, itchiness, because sometimes patients do tend to correlate both these things together. They think if they are having any itchiness, it is related to their refractive surgery. So, for example, one patient turned up. She had recently had an episode of conjunctivitis, which she did not take very seriously and self medicated at home. Now, this person had LASIK done some 8 years ago, and now she's presenting to the clinic with blurred vision. So the first thought that crossed the girl's mind was that probably her LASIK has gone wrong, and that's why her vision is blurry. But on examination, we saw there was nummular keratitis. Probably she had an adenoviral episode which she did not take seriously and self-medicated, and now there were small opacities on the cornea. So we have to also elicit history of previous infections or chronic inflammatory conditions. Apart from that, now that we have established that all of these conditions are not there, we now need to know what was the previous surgery detail, what was the type of initial surgery, what were the settings used, and if there was any complication during the procedure. We have to pester the patient sometimes to get the exact details because they are very defensive sometimes if the fault had been theirs or some other reason. So as much as we can ask from the patient and get details, it would be better. Next, coming to the second most important thing. Now that we have established that our patient has a genuine complaint and has a refractive error, we need to quantify the refractive error. And for that, always a cycloplegic refraction should be done. Sometimes some people can have spasm of accommodation and they can wrongly be assessed as a case of regression post their refractive surgery. So we need to do a cycloplegic and a manifest refraction to come to the conclusion. Most of the times, these patients who have spasm of accommodation, once you do a cycloplegic refraction and the cycloplegia sets in, the refractive error is generally not very significant. We also have to assess what is the best corrected acuity, whether the patient is accepting some refractive correction or is there actually a potential for visual improvement with enhancement. Then, of course, we have this armamentarium of so many technological tests that we can do, which can also help us decide as we move forward. So the most important test that we have is corneal topography or tomography. Now, this, apart from giving us the value of the thickness of the cornea, it also gives us the idea if the patient has an irregular astigmatism, or it can even help us identify any ectasia or excessive corneal thinning, which of course will contraindicate further corneal-based procedures. So let's say for this, in this example, we can see this is a person who was treated with LASIK 3 to 4 years ago and now has presented with some residual refractive error. So as we can see here that the thickness is not too bad and also there are no ectatic changes. So yes, this is a good candidate who can be taken up for a retreatment procedure. Then coming to corneal thickness measurement, apart from the pentacam, we also have other measures to assess the pachymetry such as OCT and USG guided methods. We just have to ensure that the cornea is thick enough for another laser procedure and that there is a good residual stromal bed. So according to literature, at least a 250 microns of residual stromal bed is compulsory so that we are not pushing the cornea towards ectasia. So this is another composite image. This shows ASOCT being done, and also we can see on the left there's a pachymetry map as well as an epithelial thickness map. So all these together, they do give us a good idea as to which direction we need to proceed to. Then we have wavefront aberrometry. Most of the times even if the person doesn't have aberration, a lot of ectasia or regression changes, sometimes it is a case of a decentered ablation that is causing a lot of high order aberrations. So this can help us delineate these cases where we don't need to push towards further correction, but we need to also take into consideration their wavefront aberrations and also the topography of the cornea. For example, here this patient had very high order spherical aberrations, but post surface ablation, we can see the cornea has been stabilized a little bit, and his symptoms have come down. So we also have to assess the aberrometry profile of the patient. Epithelial mapping, again, this can help us detect cases which are regression versus ectasia. This is also another very useful test, and it can also help us plan a topo-guided treatment in cases where there is excessive epithelial thickening or response following the primary surgery. Then comes the ocular surface and tear film assessment. So a dry eye evaluation is a must for any person who's going for any kind of refractive procedure, whether it is a primary or a secondary procedure. Because a poor tear film can also cause fluctuating vision, and sometimes some people have a severe dry eye that can also lead to their vision fluctuations and hence them landing up in the clinic for a retreatment. We also have to assess the evaporated dry eye component. So a comprehensive dry eye examination has to be done, including the breakup time, non-invasive as well as fluorescein, and we have to assess the eyelid margin and the meibomian glands, and also corneal and conjunctival staining patterns to rule out any cases of dryness that could be causing any disturbance in their vision. Now, another important fact comes here is the flap and corneal integrity assessment. So this basically comes for people who have had a LASIK done previously. This can be done with the help of an anterior segment OCT, and this will give us idea whether the flap thickness and the interface evaluation is good enough for this flap to be lifted again. Also, it can also tell us what is the residual stromal bed that is obtained. For example, here we can see this is a patient who had undergone a blade LASIK few years ago, and we can see the flap thickness is somewhere around 190 or less than 200 microns. So this can give us an idea that his residual stromal bed is somewhere around 265. And hence, therefore, this will help us when we are planning a retreatment for such a person. Now, we also can assess the epithelial ingrowth if it has happened, if the flap has shifted, or if there is any irregularity. So ASOCT can also help us identify and therefore help in treating this patient for his complication. Next comes the retinal examination. For every person undergoing refractive surgery, definitely a retinal or a fundus examination is also compulsory. And we have to ensure that there is no retinal pathology that could affect vision, especially in high myopes, because they can develop progressive lattice degenerations and even holes as the age progresses. So this has to be ruled out, and if there is any such propensity, it has to be first tackled before proceeding for any procedure. We also have to understand the patient's expectation. Any secondary procedure will never be as good as the primary results, and therefore the patient should be well aware of the fact that what he's seeking may not be entirely achievable. We have to keep it realistic, and also we have to tell them whether they are suitable for the procedure or not. So some people may have unrealistic expectations, like I want a 0 number for my eye. With both my eyes, I want a 6/5 vision. I have seen it on so and so video and this and that. So you need to explain it to them that the target is always emetropia, but there is always a slight chance of here and there depending on the corneal healing process. Some people can also have some neurological or accommodative problems, and they may link this to their vision disturbance. So that also has to be taken care of. If the cornea is too thin or irregular, or if it is not a suitable candidate for surgical procedure, then we should definitely go ahead and give them alternatives like contact lenses or spectacles, which may be less risky for the patient. And if the person is ready, then we can avoid touching his cornea, which is already susceptible to further weakness again. So we should be open to this. We should not just jump to surgery. We should give all the options that are available, and for us, the patient safety should be the primary factor of decision. Now that we have done all the thorough clinical investigations, workups, now comes the major decision-making point where we have to decide which procedure we need to undertake to do an enhancement. So based on the findings, every surgeon has their own approach. So the most important is that it should be safe and it should not lead to any further complications in future. So LASIK flapless lift and excimer laser is done if the previous procedure was a LASIK procedure and there is a good residual stromal bed and the present refractive error that is remaining is not very high. A surface ablation enhancement can be done if the cornea is too thin or when flap lifting is a little complicated or if the flap has been adhered or there are some opacities or there are some flap related irregular flap related healing responses. So it's better to do a surface ablation in such cases. Smile again, we can retreat a smile patient depending on the residual refractive error and the residual stromal bed. But if it is not possible, then we can definitely shift to surface ablation. Then IOL option if refractive surgery is not a viable option for such patients. Now, what are the common guidelines before planning any enhancement? It has to be a stable refraction, at least 3 months for a lower degree of myopia and more than 6 months for at least high myopes and hyperopes. The tomography should be regular. We should rule out any early ectasia or decentered ablations, and we should also rule out any lenticular myopia. We should also see whether there is adequate stromal thickness to perform the procedure again. Now that we have concluded that yes, this person needs a refractive enhancement, we should now proceed to the surgical techniques. So we will discuss all the surgical techniques one by one. So first, the most commonly performed retouch up or an enhancement process is basically flap lift, because most of the people who have had some blade or bladeless flap surgery done in the prior years, they turn up for regression or ectasia changes. So flap lift still is the most commonly done. It is most routinely done, and a flap can be lifted. The potential space remains and it can be lifted even after a decade of surgery. The important point is that the previous surgery should have been uneventful. And when we already know the intended flap thickness, there should also be a good residual stromal bed. Most importantly, whenever we are doing a flap lift for enhancement, we should take full care not to disturb the surrounding epithelium, because every flap lift is associated with a higher chance of epithelial ingrowth. So the surrounding epithelium has to be dealt very carefully. This is a video of how a flap lift is performed. So first we dry up the surface, and drying and indenting the surface gives us an idea where the previous flap was, apart from doing a pre-op assessment with the help of ASOCT. And then we can gently lift the flap. So like I said, even after a decade of the primary surgery, the previous flap can be lifted with utmost care, and it can give us similar results as they were in the primary surgery. So this is how it looks after lifting the flap. Then based on the topography guided treatment, the excimer laser is fired. And later the flap is repositioned. So because we are not undertaking a new process here, and it is the previous primary process that was involved, the recovery is very fast and usually complication risks are less, unless of course there is a lot of disturbance to the surrounding epithelium, which may lead to an epithelial ingrowth. So what are the advantages of a flap lift? Firstly, faster recovery, usually within the first 1 or 2 days. There is a lower risk of corneal haze, as we already know that surface ablation procedures, because they interfere with the Bowman membrane. So there is more aggressive healing response in a surface ablation procedure. So compared to that, flap lift has a low risk of corneal haze. And because there is less involvement of the epithelium here, so more predictable outcomes. Stromal ablation gives a more predictable outcome as compared to epithelial, because the epithelial layers can grow and they can get thickened and they can change the outcomes in the recovery phase. However, so stromal ablation behaves more predictably. Now that we know what are the advantages of a flap lift, we also should know what are the disadvantages. So first and foremost is the risk of epithelial ingrowth. The risk of epithelial ingrowth is so much so that nowadays people are actually shying away from touching or disturbing the previous flap, because this is a very significant complication that occurs if the flap is lifted multiple years after the initial surgery. So sometimes epithelial cells can migrate under the flap, they can adhere, they can also cause a melt of the flap, and which can lead to a lot of complications when we are planning a retreatment. If the epithelial ingrowth is peripheral, it doesn't bother much, it can be treated in a conservative way. But if it is central and affecting the pupillary area, then definitely a flap lift and, of course, cleaning of the epithelial ingrowth is compulsory. Second is the flap integrity. So LASIK flap being very fragile, especially if it was created with a microkeratome using the older techniques, it may be hard to reposition. Sometimes we are also not aware of the flap thickness exactly which was there before, and therefore in some cases the flap thickness not being known, it can lead to a double flap or other kinds of complications that can happen. There is also a limited range of enhancement because the residual stromal bed is not very thick as compared to a surface ablation. So we have to take that into consideration as well. Now, apart from flap lift, there is also a process called flap recut. So here, instead of lifting the previous flap, we make a new flap. Now, of course, this is only possible when we know the previous flap thickness and the residual stromal bed thickness. So let's say if the previous flap is very thin, we can plan a second flap beneath the previous flap, considering it as a new interface, and then we can proceed further with the laser vision correction as we do in a normal LASIK case. So it can be recut with a microkeratome or a femtol laser at a deeper plane, and it provides a clean edge when we usually do it with a microkeratome, and therefore less chance of ingrowth. But the issues are that there could be a chance of double cut, that is, there are two interfaces that are there, and separation of a first flap from the second at the edge can be little difficult. Also, each flap weakens the cornea and also severs the corneal nerve, so more chances of dryness. So this is an example of a complication that happened when a recut flap was fashioned. So this was done with the help of a microkeratome. So after the microkeratome pass, when the first flap was lifted, here we could see there is another flap here. So such complications definitely can affect your visual outcome after the surgery and also affect the patient satisfaction. So these things have to be borne in mind. Flap recut is now not preferred in general. Now, when to avoid flap recutting? If the cornea is very thin, that is less than 500 micron preoperatively, or when there is a less than 250 micron residual bed. This also applies to other laser corrections because less stromal residual bed will push it towards ectasia, which we do not want. If the topography is suspicious and is giving us a risk of ectasia, if there is already a documented previous flap complication like a buttonhole or an irregular edge, or if there is a significant dry or nerve damage condition, so we should avoid flap recutting in such cases. Now, enhancement after smile. Now that we are done with the LASIK and enhancement after a previous prior LASIK, we come to enhancement after a prior smile or a lenticule procedure. So here in the lenticule procedure, we convert the cap of the lenticule of the smile process into a flap. So there is a software in the Zeiss Visumax machine which is called the circle scan. So this circle scan helps us to convert the cap to flap very smoothly, and it is considered even safer than the LASIK redo, considering there is not much of physical activity which is required to separate the cap and flap. So less resistance and less chances of epithelial ingrowths. So this is how the circle scan works. Here in this diagram, we can see that 1 stands for the initial cap and 2 is the entry cut that we made during the smile surgery. So what the circle software does is it extends the cap, the area 3 is the extended area of the cap to make this like a flap. And then it makes a flap side cut, and with the hinge remaining here in the area 5. So again, most importantly, we have to at least wait for 3 months stabilization of the refractive error that is there, and then we can take the patient up for circle scan and then retreatment. So here what happens is, instead of a cap and a side cut or a lenticule side cut, we are now converting it to a flap with a proper flap cut. So this is the video how a circle scan works. So here we can see that the extent of the cap is here and the laser is firing to convert it into a flap. So this circular ring around the previous existing cap converts very smoothly to a flap, and then we can proceed with the excimer laser as we do in other cases. However, because circle scan has not yet been FDA approved, so many surgeons in the US do not have access to this software, and they have found their own ways to convert it using their own machines. So what they do generally is
the smile cap into a LASIK flap. The surgeon gets the instant visual result PRK, and without the risk of thin and thick people, as proprietary software on the VisuMax. In keeping with the theme of advancements in refractive surgery, surgeons were forced to innovate. Here, we demonstrate how to perform the off-label cap-to-flap enhancement using a VisuMax 5 reestablishing suction on the cornea. VisuMax laser creates LASIK flaps in an outside-in fashion to allow the patient maximal time of looking at the fixation light. The process of standard LASIK flap creation is manipulated so that the creation of the flap is intentionally stopped just as the edges of the smile cap are passed. A 120 micron LASIK flap is programmed, which correlates to the depth of the cap. Suction is established, and once the creation of the flap has passed the second ring from the outside on the left screen, suction is intentionally broken by releasing the foot pedal and by clicking the suction button on the joystick. The patient supporting system is then slightly lowered, and the proximal end of the vacuum tubing is disinserted from the laser. A thumb, glove, or some other object is used to artificially occlude the vacuum port on the laser, which tricks it into thinking that suction has been established. The surgeon engages the joystick to reestablish suction, but nothing is touching the patient's eye. The laser just thinks that it is docked on the cornea. The surgeon then resumes treatment by depressing the foot pedal, and the flap creation continues, this time on thin air. Around the 4-second mark on the left-hand screen, the artificial suction that was created is broken, and the thumb, glove, or other object are removed from the vacuum port. The vacuum tubing is reattached, the patient supporting system is raised, and the cornea is once again activated. Suction is reestablished, and the treatment is continued one final time, the last 4 seconds, which are the creation of the side cut of the flap. The process of cap to flap conversion is now complete. Notice that there was no femtosecond laser pass across the visual axis.
So this is how the people who do not have access to circle scan, mainly outside in the US, they do it. So they have found their own innovative way. What they do is, when the flap is being made, they stop the flap right at the mid periphery, and then they restart the side cut. So that way they can convert their caps to flap. Although in India, we are lucky enough to have the circle scan software, so we can simply take up the patient for that. So what are the advantages of circle scan? It gives a better corneal stability as compared to PRK. So a person who has had a smile surgery done previously can have a better corneal stability if we are comparing for a retreatment, because here the epithelium is also preserved and the stroma is not as exposed as in a excimer laser surface ablation. Secondly, it also minimizes any additional biochemical weakening by biomechanical weakening by utilizing the pre-existing cap. Because most of the laser firing that was done was in the mid-periphery area for the making of the flap. Secondly, visual recovery also is faster as compared to a surface ablation, and there is no risk of flap irregularities or incomplete flaps or flap dislocation since the original cap is itself used. It also preserves the corneal nerve regeneration. Now, when to choose circle scan over a surface ablation? So how to decide whether you want to go with a smile enhancement or a surface ablation enhancement? Firstly, patients who have prior smile who need an enhancement, definitely they are good candidates for a circle scan. And when the corneal biomechanics are strong enough and they can allow for a conversion to a flap-based enhancement. That is, patients who have more stromal bed thickness, and also who prefer faster recovery, who do not want to undergo the pain and discomfort associated with the surface ablation procedures. So in such cases, we can do a smile enhancement. Now, what are the disadvantages? Of course, unlike LASIK, when the flap is designed, it is basically modifying an existing smile cap, so which may or may not be perfectly uniform. Like for the people who are finding some innovative ways to make the cap to flap, they may have some discrepancy in their flap thickness or the cap thickness, which may not match. Secondly, lifting the cap after a very long time after smile may also lead to epithelial cells in growth, because as the time progresses after a smile procedure, the adhesion of the cap to the bed is more stronger as compared to a flap in a LASIK procedure. Technically, of course, it is more challenging than in LASIK enhancement, and the smile cap is also on the thinner side, so it is more delicate and fragile, and sometimes it is harder to manipulate without damage. So these are also a few circle scan disadvantages. Again, longer surgical time as compared to a flap lift enhancement. So when to avoid a circle scan? If the smile cap is too thin, or if the cap adhesion is too strong, making the separation very difficult, or if there are very significant high order aberrations, which would definitely benefit with a topo-guided surface ablation. And lastly, if the patient already has an epithelial ingrowth risk due to prior trauma or very late enhancement. So in such cases, it is better to shift to a topo-guided surface ablation. So now that we've spoken about surface ablation, currently surface ablation is very popular for any kind of enhancement because of the advanced technologies that are available. Even more popular than a flap relift in majority of the centers, because most of the surgeons have observed over a period of time that a flap relift has a significant chance of epithelial ingrowth. So those who are not willing to take that chance, definitely they have shifted towards surface ablation for enhancement. So when is surface ablation planned for enhancement? If we cannot lift a flap, that is, if the flap edge is not visible, or if the flap thickness cannot be determined or located properly, then it is better not to fidget and shift to a surface ablation. Secondly, aside from alterations, basically a surface ablation is identical to a PRK surgery. So when the surgeon is not very technologically confident and they do not want to take too many risks, it is always better or safer to shift to a surface ablation. And also this applies to the patient. If the patient is too scared or too affected by the procedure, it is better to go for a faster surface ablation than in any kind of complicated technical surgery. The most important aspect is the removal of the epithelium without disturbing the flap. So PRK gives us this benefit that we don't need to disturb the flap. Once we know the flap thickness from prior, we can simply go ahead and remove the top layer of the epithelium without doing any disturbance to the flap and proceed with the ablation. We also use mitomycin C always in enhancement procedures to reduce the chances of haze. Also, there is longer tapering of steroid which is required in surface ablations. So a surface ablation for enhancement essentially is similar to the PRK procedure that we do. Usually, alcohol is not used, and also not vigorous actions are not undertaken when we are trying to remove the epithelium. We do not try to interfere with the flap area, and generally the epithelial removal is done in a radial fashion from center to outwards, so that we do not disturb the pre-existing flap. Apart from this, the whole procedure is similar to a general surface ablation or a PRK. Mitomycin is applied at the end of the process. So what are the advantages of a surface ablation? It is the safest choice for patient with residual stromal bed thickness, which is very low. So for thin corneas, of course, surface ablation enhancement is the preferred choice, and it also preserves corneal biomechanics better than LASIK or even smile enhancement, because it is located on the surface, so the posterior stroma is not affected, and therefore lesser risk of ectasia. There are no flaps or no flap related complications, and it is also ideal for late enhancement in cases where there was a prior smile or LASIK done, but now separating the flap or separating the cap may be difficult over a period of time. and if the cap or flap is not evident. So a surface ablation is ideal for late enhancements. Also, with the help of surface ablation, and if we club it with a topo guided or wavefront guided treatment, we can also take care of the aberration profile. What are the disadvantages? It has a slower recovery than LASIK or circle scan because the epithelium needs to grow back. So definitely it takes more time. It can be discomforting to the patient, temporary pain and also irritation. It has a higher risk of corneal haze. However, the use of mitomycin C has definitely brought down the incidence of haze in a surface ablation procedure. And with the surface ablation, because the aggressive epithelial healing response is there, so we need to taper the steroids over a long period of time, and therefore all these complications associated with a longer steroid taper are also associated with this. So this is a cumulative comparative table for all the three procedures that can be done for enhancement, which is a smile enhancement using a circle scan, or a PRK enhancement, or a surface ablation, and a flap lift. So as we can see, recovery is fast in circle scan and flap lift, but slow in PRK enhancement. Pain postoperatively is again moderate to severe in a surface ablation. Risk of corneal haze is more in surface ablation. However, flap-related irregularities and complications are not here. Epithelial ingrowth risk is not there. And even biomechanical stability is the best with a surface ablation. It is also more suitable for thin corneas. The ease of enhancement is more. It is a straightforward, although it is a longer healing process. Long-term dry eye risk is lesser, but there is a long-term steroid use need. And for high myopia enhancement, a surface ablation is preferred. So when to choose what? Circle scan can be chosen when the patient had smile and needs an enhancement, when the person is not willing to go for a slower recovery period, the cap is not strongly adhered, or it is a very, very early period of regression, and the cornea has enough residual bed. On the other hand, PRK or a surface ablation, when there is a limited corneal thickness, high risk of epithelial ingrowth if we try to lift the flap, or there are higher order aberrations or a very irregular astigmatism, and the original smile cap or LASIK flap is too difficult to lift. Lastly, flap lift we can do when the patient has had previous LASIK and needs an enhancement, and the original LASIK flap can be safely lifted without any adhesion issues, and also when the patient wants more faster recovery as compared to a surface ablation and residual stromal bed is thick enough. Now, this was about the patients who have had regression after primary surgery, but there are also a subset of patients who have had ectasia after their refractive surgery. So in such cases, enhancement is not the priority. The priority is to stabilize the weakening of the cornea. Therefore, the first process to be done is a corneal collagen cross-linking in order to strengthen the cornea. It will not directly improve the patient's vision, but at least it will prevent the symptoms and features from worsening further. In such cases, once a C3R is done and after a sufficient amount of time when the cornea has stabilized, we can give them the options of specialty contact lenses as temporary measures for a better optical quality. But if, let's say, some patients may not tolerate lenses well, then there are a few surgical procedures that can be undertaken. However, post-LASIK ectasia is a class in itself, which is beyond the scope of this. I would just brush up on these. So you should also know about the Athens protocol. So Athens protocol was developed by Dr. Kanellopoulos, and according to this protocol, if there is a sufficient corneal thickness and if the ectasia is not severe, it is mild to moderate, then sometimes we can club a topo-guided PRK and a C3R at the same single setting in order to regularize the cornea as well as halt its progression. So ideally, the concept goes that a cornea which is prone to ectasia should not be lasered. However, the Athens protocol is a different entity in itself, and it is applied to those people who have lesser degrees of ectasia or a very early ectasic change with good corneal thickness that can benefit with the combination of two procedures. So mostly it is done in two steps. First, there is a topo-guided PRK done, and the ablation depth is not exceeded beyond 50 microns. It is mainly done to regularize the cornea and not for the visual correction alone. Second step is a high fluence accelerated corneal cross-linking. So this is done at a 10 milliwatt centimeter per centimeter square for 10 minutes, unlike the resident protocol, which is done at 3 milliwatt for 30 minutes. So one should also be aware about the Athens protocol. Other cases where there is a good stromal bed, but lot of irregularity in the cornea, we can also combine a procedure like an Intax, which can sustain some corneal biomechanical strength. And at the same sitting, we can also club it with a CXL procedure. So this is how an Intax can be placed with the help of a femto laser. We can make a channel where the Intax has to be placed and a side cut, followed by this bifurcated handle is used to enter the corneal pockets that have been made, and then the Intax is inserted. Once the Intacs are in place and suture has been applied, then we can do the C3R in the central area. Why Intacs with C3R in the same sitting is considered better is because after C3R, there is a very strengthening and tightening of the cornea, which may lead to problem with the Intacs inclusion into the cornea. So usually these are clubbed together. There are other school of thoughts also who prefer doing it in a graded or a stepwise manner. So after this is done, the central area, so the central zone is debrided of epithelium, and the C3R process is continued as usual. So for patients who are not suitable for any corneal-based procedure, we also have lens-based procedures for enhancement. So patients who have very, very thin cornea, who have very, very high refractive errors beyond the safe limit of laser treatment, or sometimes presbyopic patients who do not have any complications, but they need both refractive correction as well as near vision improvement. Then we can also do it in cases with post-LASIK ectasia who may not tolerate further corneal surgery. So lens-based procedures again can be divided into two. It can be an ICL or a phakic IL procedure, or it can be a refractive lens exchange. So usually for younger people who have had stable refraction but a weak cornea and good anterior chamber depth, clear crystalline lens, but non-tolerant to specialty contact lenses, they can definitely go for a phakic IL implant. The advantage is that here we are not using any corneal tissue and we can cover high errors, and of course it is a reversible procedure. But let's say the person is above 45 years of age, they have stabilized ectasia, but they also want to get rid of their presbyopic correction, and they might be starting to develop some cataractous changes. Then a refractive lens exchange is better for them, and the advantage is that it treats the cataract as well as the error both. And nowadays we have very high technology multifocal IOLs and EDOF IOLs, which can give very good quality of vision. However, still, multifocal lenses do share their fair share of disadvantages like glares and halo. And the most important is the permanent loss of accommodation. So some people may not be very comfortable. So this has to be discussed in detail prior to the surgical procedure being planned with the patient. Whatever is his expectation according to his day-to-day functional vision, whatever he needs, he or she, that has to be planned. Sometimes we also combine these procedures, such as in this case, it was a young patient who had undergone a cataract surgery previously and now was not very happy with the high refractive error that was there. So he wanted to get rid of it. So instead of planning a corneal procedure, because it was in the range of -10 or 12, we instead decided to do a piggyback ICL. So on the top of the pre-existing PCIOL, a piggyback ICL was placed to correct the patient's vision. So this is also an option. We can combine the two as well. So these are the approach to enhancing post-LASIK ectasia. Basically, cross-linking is the most important process in ectasia cases. And once the cornea has been stabilized, then we can further plan few surgical options in such cases. This is beyond the scope of this class and will be discussed in detail later. There are also a few scenarios which can happen during the surgery, which were not thought of before, such as incomplete flap. So in such cases, if the side cut has not been made, we can redock and we can choose a different thickness and we can again complete the flap. So this is one example where intra-op complication can be managed immediately. Sometimes there could be flap tear. So we can see here this patient has a corneal opacity in this area. So what happens is once the flap is fired and we are trying to delineate and lift the flap, there is a slight flap tear here. So we can see here there is a flap tear, although it is in the periphery, so it is not affecting the patient's vision. So again, the procedure can be continued. However, if it was in the center, then definitely it should be aborted and the person should be explained. And after 3 to 4 months of stabilization, maybe a secondary surface enhancement could be planned. So in this case, it was easily placed back, and we can see that the central area is regularized. Sometimes there could be areas of blocked laser delivery, such as in this case. So there was a hair follicle. Due to this hair follicle, the laser did not fire in this area, and therefore, while the flap was being separated, there was a flap tear in between. So, of course, because this is crossing the visual axis, definitely it will have a lot of visual symptoms and even higher order aberrations for the patient. So, these patients need to be counseled very well and explained about the process. And maybe 3 to 4 months later, if there is any residual error or aberrations, we can do a surface ablation procedure for such patients. For epithelial ingrowths, like we already discussed, even if there is a lot of epithelial ingrowth which is affecting the visual area, we need to lift the flap. So here we can see that flap has already melted in some part. After lifting the flap, we have to clear the undersurface as well. So it should be thoroughly done. For peripheral epithelial ingrowth, even an Nd:YAG capsulotomy laser can be used for blocking the progression of the ingrowth. So the take-home message is that thorough evaluation, safest method should be chosen. Post-LASIK ectasia requires special care and has to be differentiated. And these cases do not do well with a standard LASIK retreatment. We need to first stabilize. We also can consider lens-based option. We also have to talk to the patient about their expectations. They should be realistic. And when in doubt, avoid any further corneal surgery. We can give the option of specialty contact lenses, which can provide excellent quality of vision without compromising on the safety. So this is a small flowchart just to summarize what we discussed. Let's say a patient turns up for enhancement post-refractive surgery, and we know it is an uncomplicated case, and we know the history, and there is a good residual stromal bed thickness, then we can plan a enhancement of the previous procedure, such as a flap lift or a circle scan. But however, if the residual stromal bed is not good, then it is better to shift to a surface ablation. On the other hand, if the person is more than 45 years of age and also needs a presbyopia correction, then probably a lens-based procedure is better for him or her. If the enhancement history tells us that there was something complicated that happened, or if we do not know exact history previously, and we can see that the patient has a lot of higher order aberrations, maybe due to a decentered ablation, but no chances of ectasia or no present symptoms of ectasia, then we can simply go ahead and do a topo-guided ablation. However, if there is presence of epithelial ingrowth and previous flap lifting has been done, so we can again go and lift the flap and clear the epithelial ingrowth, and depending on the severity in the same sitting or on the next sitting, we can do a surface ablation for the patient as well. If let's say the history is also not known and it is complicated, or the person has ectasia, but a good pachymetry along with ectasia, that is still we have about 400 microns of corneal thickness. So we can then plan either a topo guided ablation with CXL or intact with a corneal collagen cross-linking. But if let's say the cornea is too thin to even let us do a cross-linking, then we may need a penetrating keratoplasty. However, if the cornea is thin but CXL is still possible, we can also think in terms of a staged procedure, that is first a cross-linking, and then later on we can give the specialty contact lens, or maybe if the person is not tolerant to contact lens, then a phakic IOL could be given. So this is the gist of all the procedures that we discussed. And thank you so much for your patient listening. I hope I was able to cover the topic as required.
Thank you, Kanika. That was a wonderful presentation, and you almost covered every aspect of enhancement. But today we have the mother of smile. We are so lucky to have Dr. Rupal with us. Ma'am, please add on your pearls to this session.
Kanika, you've nearly not left much to be added. I just wanted to cover, I think, add a few points. One is when you are trying to find out why the under or overcorrection occurred, you mainly talked about the eye and the cornea is a factor. But sometimes there are also external factors, like an AC blast flowing over the eye will make the cornea very dry, and then you can have tendency to have overcorrections or a very harsh light. Or if you're taking too long after opening the flap to go ahead and do the ablation, that can also lead to overcorrections. So if you're constantly getting overcorrections, that's one factor to look into. Also, sometimes the lasers are not maintained well, and that can lead to under or overcorrection or an irregular or inhomogeneous ablation. So again, look into your results carefully so that you can avoid having a series of such under or overcorrection. One more thing that I wanted to add was that autoref is not a good guide post refractive surgery. And I see that many people depend on autorefs for their refraction post-op after post-refractive surgery, which should be avoided because it's not going to give you a correct reading after refractive surgery. Most autorefs depend upon the fact that the anterior to posterior ratio is a constant. So they're taking it as a constant, which changes now because you do a corneal refractive surgery. And therefore, the autorefs can't give you the predictability as what you would have in a virgin eye. So this is one thing that we all have to be very careful about and not depend on our autoref, but learn retinoscopy. Another thing is, as you rightly pointed out, epithelial mapping gives a lot of information. So it's becoming an important part. There are systemic causes why you would have refractive errors occurring after a while. So a careful history taking, especially about diabetes, pregnancy, OC pills, and any PCOD is important. And you'll find that sometimes people don't give this history and they are having actually refractive errors because of these hormonal or metabolic changes in the body. Also, it's a good idea as a practice to note down everything, all details that happened in the surgery. So we have been practicing that since a long time. And so we write down what procedure was done, where was the hinge, which microkeratome or femtolasic was done, or so at what thickness the flap was done, what was the residual bed that was remaining, how much ablation we have done, what was the lenticule size, what was the cap size, and whether there were any flap or laser related issues during the first primary treatment, so that it's easier decision later on to know whether you can do a retreatment here using the same flap or not. One more thing I think, Kanika, that you missed out is that you've always said about the pachymetry, but there is also a physiological limit to what you can mold a cornea. So if the endpoint is going to be too flat or too steep beyond the physiological limit, then that cornea is not going to remain stable. And that's also one of the limiting factors in choosing whether you should be doing a retreatment. So if somebody has already had a cornea coming down to 35, 36 diopters, this cornea is not going to become any more flat and remain flat. Also, if it does, then there are lots of aberrations coming into picture. So you should not try to flatten a cornea too much or steepen it also too much, even though you have enough pachymetry remaining. PRK over LASIK flap, always use MMC as you rightly pointed out. And one more good method would be to do it transepithelially so that you don't disturb the original flap. So, and if you're going to use femto to make a new flap, then you have to go clearly 20 microns away from the original bed. But having said that, if you're doing it in the same setting, it's better not to change any settings, and go ahead and try and enter the same plane because that's the plane of least resistance. So these are my 2 cents. But Kanika, I must say you did a wonderful job. And it was expected, but you actually surpassed the expectations.
Thank you, ma'am. I'm honored that you're here and you could point out what I missed, and I will also take care to remember all these points in future as well.
Thank you for making me a part of this, Pratiksha.
Yes, ma'am. Ma'am, I also have one question that how much time do you wait? Like do you wait exactly for 3 months for enhancement process?
No,
Like patient
I
may get
don't.
very restless
I
in
don't.
during these.
If I know it's a primary undercorrection, so the refraction is not changing when I call them every week after 10 days, 15 days, then I know it's a primary undercorrection. Then I take it up as early as a month's time also. But what I like to do is immediately post-op, at least 2 readings at a gap of 15 days, which are having the same reading. Then only I go ahead and do a retreatment, because you can't keep doing retreatments again and again. Or if I know that there was a reason for undercorrection, like somebody had worn a perfume and came into the clinic, into the OT, or that there was too much wetness in the cornea, or the energy was not enough because my laser was not really firing well, or I had this AC blast blowing over it. And so if I know that there is some reason why you would have under or overcorrection, then I would take it up early. But otherwise, as Kanika pointed out, it's better to wait till complete stabilization. And the best way to wait is to give them cyclosporin eye drops, because that would also improve the tear film, and the 3-month course will get over. That gives more corneal stability and also gives you a better tear film. So now next time on when you go, it's going to give you a better healing response. If I'm going to do a surface ablation as a retreatment, I make sure that my vitamin D levels are okay, and I also give them vitamin C post-operatively for enhancing the effect of my surface ablations.
Also, ma'am, how much is the minimal refractive error you take? Like it could be like 0.5 or something. Do
So
you correct that also?
yeah, if the patient is unhappy, I do. If it is there in both eyes, and if the patient is unhappy, I tell them that the predictability of the procedure is this, but still we can try in one eye. If that does well, then only we'll go ahead and do the other. And most times they're happy with just one eye retreatment.
That was really wonderful to have you, ma'am.
Thank you
Cannot be
so much. It's
justified
a
in
pleasure
words.
for me also.
It was a wonderful session. I hope everyone has learned so much. Kanika, you want to add anything?
I'm just asking if we have any questions. Surveen, do you see any questions on any of the platforms that we need to ask, ma'am?
Ma'am, there is one question which states that is, is it possible to do a smile over smile?
Yeah, so we have done a couple of cases like that. It's not available commercially, and it's not really been so the technique is not really that refined or depicted. So the Zeiss people or the manufacturers are not recommending it right now, because creating two different planes would also mean that you have to calculate how much would be the additional effect. So it's not going to be the same if it is two different planes rather than only one plane. So, they need to make it really refined to be able to retreat the 0.75 or ones that are left behind. So if the refractive error is not too large, it's not a good idea to make another smile, over smile, because if you don't have really a good uh, way in which it has been, so it's not been defined how to do it and how to keep the cap as the cap and go in the same bed to remove that extra tissue. So the calculation may fail. So right now, best way would be to do it as a circle software, open a flap and do it. Another good way, if you are afraid of, so I have opened a LASIK flap even after 18 years, and I have had no real problems. I have very few cases in which I have had epithelial ingrowth post opening the same flap. But another method to open the same flap would be also to use just a side cut mode of the laser. So use the retreatment or uh, in the femtosecond laser, you can do only the side cut. So if you do only the side cut, it would be creating like a new cut. So chances of epithelial ingrowth will be much less. So you don't make the whole plane, but only the side cut.
Okay, ma'am.
Ma'am, does your experience say like more chance of regression with the older machines compared to newer ones? Is there
I would
any
not say that.
study like
No, I would not say that. In fact, sometimes I'm surprised when people come with their children to get the refractive surgery done. And for my interest, I make them sit. In fact, today there was a patient who was 15 years post smile. And she was in the study, and she came and she was presbyopic now. So she said, "Oh, now I need to wear glasses." And she was exact plano for both eyes. I have also seen even normal LASIK patients with microkeratome not regressing. So even those lasers were not really giving bad results. It's the cornea and its property which mainly decides whether your results are going to be stable or not. And a procedure like SMILE definitely helps because the healing response is smaller, the inflammation is smaller, and therefore the stability of result is much higher.
Thank you, ma'am. Wow.
Thank you so
It was a
much.
great session.
Kanika, thank you very much. It was really extensive and nice.
Thank you,
Thank
ma'am.
you for making me a part of this. Have a
Thank you,
good
ma'am.
evening. I think we can all leave now, right?
Yes, ma'am. I think we can call it a day. Thank you, Pratiksha, ma'am. Thank you, Rupal,
Thank you,
ma'am.
Pratiksha. And thank
Thank you,
you,
ma'am.
Dr. Kaur.
Thank you, Kanika.